Okay, so this IC is on ultra wide field imaging, whether it's a technology we follow or it's just a hype, and whether it's useful in our day-to-day activities or not. Whenever a newer technology comes, we like to compare it with the existing technology and look out for any specific advantage, and we evaluate all those advantage based on the cost factor also. But ultimately, availability and utilization for an individual practitioner is important. Now, we'll be looking at 4 technologies here, but before that, let's define what's ultra-wide field imaging. It's a single capture image centered on fovea, which captures the retinal anatomical features anterior to the vortex vein ampullae in all 4 quadrants. That's the definition. So as you can see here, we have these ampullae all around, and we are seeing beyond that. That's what is ultra-wide field. And just to give a comparison, ultra wide field imaging is when we see all these areas as compared to wide field, where we are seeing only up to the ampullae, not anterior to it. Then this is the standard fundus photograph, which gives you 45 degrees. This is single field of an indirect ophthalmoscope, which you have to keep moving to see the periphery. This is the direct ophthalmoscope, and this is slit beam. So definitely at one shot, what you see is definitely going to be better with ultra wide field, and that's what we are looking at. Now we are comparing 4 technologies. First is the Optos, then Mirante, and then we have Spectralis and Claris. Now, Optos, we have 3 talks. I'll be talking mainly on the color and red-free with choroidal. Dr. Anand Kumta will be talking on autofluorescence, and Dr. Vatsal Parekh will be talking on the wide field with wide field OCT also. And Dr. Prashant Bavankole here will be talking on Mirante, and I'm very proud that his Mirante images have been on the cover of Ophthalmology. It's a great honor to all of us from India. And on Spectralis, we have Dr. Sharad Bomaj. He has again, it's an honor to have those 2 equipments with him, both the equipments, which I think is a very rare combination. So he'll be telling us a comparison, real life comparison between the 2 instruments. And ultimately, we'll have Dr. Deepak Bhatt talking on Claris, which also is in wide field imaging by Zeiss. So I'll start with my presentation. Okay. So there are no financial interests. I think all the speakers, on behalf of them, I will vouch this, that there's no financial interest in talking about these products. Now we are talking about Optos Daytona. I am using this instrument. Daytona is an equipment which doesn't have ICG and FFA. It's pure color, and software wise you can convert into red free as well as choroidal imaging, and additionally you can take one more scan which gives you autofluorescence. A very small foothold of the machine. This on this iPad, like you can put in the data of the patient. This is the server, and you have the display here. A very compact thing. So a patient is placed here, and through this peephole-like thing, he peeps into the machine. There is an ellipsoid mirror there, which captures the images within a few seconds. There is in that bowl, he sees this very well-defined marker. And as soon as he sees this blue, he is too close to the machine. He has to but in the green position. Red is too far off. So as soon as he sees this in sharp, the photo is taken within a second. So this is what type of imaging you see within a few seconds. Can I dim the lights a bit? So now, in very short, what is the principle? It has it is an ellipsoid mirror with 2 focal points. The first focal point acts as a pathway for laser to focus on the retina, and the second focal point allows the coincidental focusing of the patient's eye. The resolution is about 20 microns on axis and 40 microns off axis. It utilizes 2 lasers, the green laser of 532 nanometers and red of 635. The machine enhances the retinal images using the 2 laser wavelengths to magnify and separate different layers into color components, but these are pseudo colors. The green, as you know, penetrates in the upper layers of the retina, whereas the red penetrates to deeper layers and can be separated. Now the principle is that they create a focal point just behind the iris, and then the laser pivots around it, so you get a very wide field of capture on the eye. And these images are from the inside of the eye. And very shortly, the key benefits, you get 200 degrees or almost 80% of retinal view in a few seconds. almost instant display on the monitor screen, and software can toggle between red-free and choroidal images. All this is on cloud storage, so that you don't have to bother about the images you take, because all images of our high data, and it reduces the in and out time of the patient. So let's look at the images now. This is a standard color image which you get while screening the patients, and this is a standard red-free you get. This is just in the software you have to check. You don't have to take a separate image for this, and this is the choroidal imaging. You get autofluorescence, and the resolution is so good that even if you magnify it 10 times, the resolution doesn't go down. More about this will be from Dr. Anand. Now, usually we take a straight ahead image, but if you want to go to the periphery, you can still have, within a few seconds, you can do an up gaze, a down gaze, a left gaze, and a right gaze, and the machine immediately gives you a collage and gives you a montage where, as you compare with the standard image, like you can see this vessel here, here you can see still more. So from 200 degree, you can go almost up to 220, 230 degrees after the montage occurs. Now, as you can see here, many a times you may see some lashes coming in between, but with high myopes and with little tricks by the person who takes the image, you can almost get a 220, 230 degrees without any lashes coming in. Now, what's the use of having these extra images? You can see here we are taking a lower gaze image, and it's a small atrophic hole, and the snail track degeneration is well seen, and you don't miss them. You can see a peripheral retinal break with small fluid cuff very well. A retinal detachment partial RD. I've just blown up this image, and you can see a break here. And not only that, next day when the patient comes for a post-op visit, first post-op, you can immediately get a very clear image, see that retina is attached, breaks are well on the buccal, cryo is there, there's an air bubble here, retina is flat, macula is flat, and 1 month down the line again. So following up this patient with wide field becomes very easy. You get excellent images, and you can see if we have not missed any thing. Now, just to give in perspective how this technology is useful, this is just 2 days back this patient came to me. On clinical examination, I noticed that there is probably an NVD here. So I asked for an FA. This is on my own machine, but a new technician, pupil not well dilating, there's little cataract. So you see the quality of the image, you just can't make out anything. But we did an FFA, so we were sure that there is NVD. Now look at the Optos image. Here you can see NVD, venous loops, some hemorrhages here, cataract. Blow up this image, this NVD becomes prominent, but you do a red-free, very prominent. So with this, you don't have to even do an FA in such patients. You can straightway document this and start the laser treatment if you want. Now, if you have this something like non-ischemic CRVO, you convert into red-free, you get a whole thing, and these hemorrhages all well documented. Patient comes for follow-up every month, you just keep repeating it and see how the hemorrhages are clearing. Again, you blow up, you can see NVD, NV, venous loops, irmas, all in one shot with the red-free. Patient treated, you do the same HST as shown you, you just document it. So whenever patient comes back and you have to see how the thing is behaving, you have a good record. Now this patient had multiple breaks, and I had to do an laser, but she was very uncooperative, blinking, moving. So I just finished the laser, and I said I'll do an image so that I don't have to see that everything has gone well. And you can make out here that this was missed because the patient was not cooperative. So I said, okay, you can come after a day or two and I'll do the rest of the treatment. So documentation and checking what you are treated has gone well also can be done with this. And again, patient who was not fit for FFA, you did this red-free, and you could see that NV here, you can document it, and you don't have to do an FA to start the treatment. Similarly, we are doing screening for a general patient who comes for a follow-up, and you see this, you blow up, and you can see that there is a definite ERM there. Or again, patient who came for regular follow-up, you see that there is an laminar macular hole with cellophane. On this patient who had BRVO, had new vessels, underwent laser, but you can see here that this new vessel was persistent even with laser. So we gave an anti-VEGF somewhere around 17th of October, and on 27th November you can see that the NV has gone off. So following up this patient, again you don't have to repeat FFA every time to confirm that whether your treatment has worked or not. Choroidal imaging, the images assist in demarcating things like choroidal detachments. You can see your laser burns which are done earlier, and you can also make out choroidal sclerosis. This is post-trab, patient had choroidals. You can take a photograph and then keep following these patients and accordingly manage his treatment. You can see this laser burns. The patient had undergone focal laser a few years back. Clinically, we couldn't see much, but if you do a choroidal imaging of this patient, you can make out each and every burn, so you know whether you have to give some additional treatment or not. And similarly for PRP, you can make out how the laser burns have been placed, areas whether this needs filling up, we can decide about that. Again, patient post-trauma, we screen the periphery, but you can see here choroidal tear very well documented. Clinically, choroidal sclerosis, you do a choroidal imaging, you can make out the extent of the choroidal sclerosis. Post-operative follow-up also, image comparison can be done. This is pre-op, young diabetic, she had macular traction, we did surgery under silicone oil, you can see the retina is flat and she's doing well. We can also screen the periphery and note that there was no active break there remaining. Following up the patients on monthly or 6 monthly or yearly basis, you can compare the images of each eye, and we can get 9 images at a time to be compared. As an additional finding, it helps in even documenting cataracts. So you can show to the patient that both eyes, we have done the imaging, that is cataract, and even without pupillary dilatation, you can decide about cataract surgery. This young female had narrow angles, we couldn't dilate her, but she had diabetes for 10 years. So we did her as it is because we wanted to check the periphery, and even the center part showed good changes at the macula, indicating that she had diabetic maculopathy. So again, even with the peripheral screening, it is good to detect the central findings also. Very useful in children. If you just talk to them, play with them, and make them sit on this machine, it's easy to capture their images, and this is what you can get in a young child also. Good retinal images, so we don't have to dilate them, they keep crying and they don't get dilated well. So I found it beneficial as a technology to screen the periphery, to detect changes, to follow him up, to see how your surgeries work. And especially in these situations, it is very useful. Patients who are not tolerant to light, patients who have problems following dilatation, they don't want to get dilated because they have to drive back home. Uncooperative children, patients having contraindications for FFA like pregnancy, renal failure, past allergy, or who just refuse FFA. All suspected narrow angles now, they don't have to wait for me to decide whether this angle is narrow or not, whether the patients can be dilated or not. We can straightway do their Daytona, and then they can come to me, and later on I can decide whether it can be dilated or not if necessary. And all the allergies, people having allergies to dilating drops, we have a problem how we treat them, but at least for the follow-up, we can use Daytona to see how they are doing. And certain basic advantages of the technology, auto capture mode, images are taken instantly, and there are no moving parts. So the just patient holds the machine and sits there, and the image is taken. And it is very easy to train the staff. Within a few cases, the staff is trained, so you don't need a specific technician. You saw how my color photograph came with the machine because the technician was not good. And other advantages that it's higher technology, so you can shift it anywhere you want. You can see now yesterday only I was here, a young patient of mine, one-eyed young child, started complaining she's seeing some black spots. So they called the patient, did a Daytona, sent me on WhatsApp. I could talk to the father immediately. So very good technology to assess patients and counsel them. So to conclude, Aptos Daytona is a very good technology, and it's here to stay. It allows comprehensive eye care without compromise. Now, once cheaper version of this or similar technology is available, I think it will be as common an instrument as an auto-ref. We just have to wait for that day. Thank you. I would now request Dr. Prashant Bawankule to present his Mirante imaging system.
Thank you, Dr. Nitin, for this wonderful opportunity and including me as a part in your IC. ये कहाँ चला गया यार, इसका मार्क कहाँ गया, इसको ऑन करो, फुल स्क्रीन करो. फटाक से कीजिए. क्या हो गया इसको? अरे सभी 4 दिन से हो रहा है. हो रहा है. नहीं हो रहा है. उधर आ रहा है नहीं. आ गया. गुड. Okay. So here I will be presenting a new technology, that is wide field, ultra wide field angiography and imaging system. This is a multimodal imaging system. This is the advantage. We get not true colored images, but the advantages over other system is that here they use 3 lasers, unlike Daytona or any other systems available, and therefore it's quite closer to true natural images. So how has it helped me in my practice? Let us understand through this. I don't see the screen moving over here. So, well, this Nitin has already briefed you, so why we did it. This is what the conventional and all the things we see, wide field and ultra wide field. I would just come directly to my part. The system offers us the advantage as well of a wide field OCT. The standard OCTs, we get a section of 9 to 12 millimeter, while in a wide field here you get a 16 millimeter, and so you can pick up extramacular pathologies like choroidal melanoma or a RD versus retinoschisis. I would be subsequently elaborating the cases I will be showing. So like directly we will move to the certain clinical situations, like what happens, what are the advantages which I get when I am doing a case of a diabetic retinopathy. So you can see actual cases of non-perfusion, quantify the non-perfusion, which we really talk about. We should have 10 diopter, 15 diopters, then we should treat the laser in a case of a BRV or something like that. You can pick up a peripheral NV, and you can talk about doing a guided or a targeted PRP, which we talk about being less damaging to the laser. So now look, this is the one of the patient who had undergone an angiogram elsewhere. This is a case of a PDR. This is a case when we did at a wide field angiography, and you can see for yourself the difference what you are seeing. See the extent of the disease. This was a lasered patient. You can see a poorly done PRP and needing much more. We did an angiogram, and now it is speaking for itself. See the amount of dropouts. I don't need to talk more. We all are a retina specialist, and this is ultra wide field. You can see. So actually where you need to treat, you can understand. So I don't need to tell. Now looking at RVOs, this is what we can get in a standard fundus and a angio which area which we see. Now look at a ultra wide field. Look at the extent of the disease where you can actually see. Can I have a pointer over here? Yeah. This is the whole thing. While here previous you could see hardly this. So you would treat this area. So now the concept of, even in a case of vascular retinopathy, to go beyond equator to complete a sectorial or a pan-retinal photocoagulation, you are justified in doing. Otherwise, a standard teaching would be to treat up to equator, moving from vascular arcade up to the equator. But this cases will convince you why you need to go beyond the equator. Now this is what the ultra-wide field is. You see the extent of the damage. Now coming to case number 1. He's a pulmonologist from our town who had a BRVO. He was with us for a long follow-up even before I got a ultra-wide field. He had macular edema secondary to it. This is what I did, an angiogram for him, and we treated him with anti-VEGFs. And every 3rd, 4th week he would need further injections, and we did not understand how to proceed. Then by that time we had this machine, and at that point we did an angiogram, and you can see the extent of disease over here. You can see the dropout even in the periphery. So we decided that what we should do is we'll target these areas as well to treat beyond, and this is much beyond the equator, and we did treat it with a targeted peripheral laser only, not the sectorial laser which was earlier done, and we could get a resolution of the edema. This is how what we learned. We learned that, yes, and then we went to the literature which says that vascular abnormalities in diabetic retinopathies are quite beyond the equator and needs treatment, and therefore UWF will help you in picking up these areas. This is what literature always told us, but we never bothered about it. Now case number 2, another case which was diagnosed at cystoid macular edema and was advised Ozudrex. This person comes to me, you see ultra wide field, I knew it is a retinoschisis, and a ultra wide field, I get a 18 millimeter, 16 millimeter OCT scan, and my diagnosis was clear. But yes, see what happens is, even in a case of a retinoschisis, had I done angio, I would have got this. But when I did an wide field, I could see peripheral vascular looping as well. So a vascular response in a case of a retinoschisis, which we learnt in literature, is what we saw over here in a case of a retinoschisis. Now this is what exactly I am trying to show. The vascular response in a case of a retinoschisis, which might need treatment, be it in the form of lasers or you want to treat it with anti-VEGFs, is a matter of choice. So this is how we learn from it. Now case number 3. This was a case which was diagnosed at epiretinal membrane and was posted for surgery. She was a young girl. It was not convincing for me. So this was the picture. Yeah, it was almost a retinal disc drag as well as this. We thought something is fishy over here, and when we did, this is post surgery, somehow I missed my angiogram over here. It was a case of FEVR, in fact. So we had to do a vitreous surgery. We had to treat even the periphery. This is a Ozudrex implant as well. So a case of epiretinal membrane. Yeah. FEVR. So there was a vascular tissue which I could see through it. Somehow I misplaced this particular angiogram. We are not able to place. And so we had to target, when we went for vitreous surgery, we had to treat this part also of the disease. That is what we learned. Now coming to another case. Hypercholesteremia. You could see this multiple dot hemorrhages on a standard fundus photograph, and what do you see on an angiogram? A terrific shutdown. All across the peripheral shutdown. While the clinical photograph, if I go back, this is all I could see. The whole disease was in a periphery. Now look at it, how a wide field angiogram can help you in making your diagnosis easier. So I don't need to say what I need to treat you. Another case, 26 years female. Now this is the case of a treated case of choroiditis. She complained of blurred vision. Well, I could see the scars. We did an angiogram and it was like this. It was showing the scar staining. Look at the color photo. We did an ultra wide field angiography. Yes, scars were only scar staining, but if you see, the dropouts have started in the periphery. So a choroiditis associated with a ischemia. Now your line of treatment is totally different. You don't need to just treat it. You need to treat it with lasers if you think, or treat it with an anti-VEGF, whatever is your choice. Case number 6. She was posted for vitrectomy for combined vascular retinopathy. Well, this is the picture in that eye, and other eye was done elsewhere. We thought on a wide field angiogram there is something abnormal. I was not very convinced. So we did an angiogram for the other eye, and this is a publication cover page of ophthalmology. This is Takayasu's. So we needed to treat the better eye first, which was asymptomatic, and ultra wide field changed my treatment totally. Case number 7. Now a young girl who came to me had a thusical eye in right eye, and she came to us for her father was operated for glomus jugulare. Grandfather had some history of brain tumor. This was the picture. Can you see certain small vascular? So if in these machines you have the imaging system where you can get a camera and see it in a high magnification. We advised FFA. Can you see some vascular tumors there? Yes, which was never possible to us. This is angiomas, von Hippel-Lindau. We treated her. This is now a post-operative follow-up. We went to father. We asked him to get a wide field angiogram and see that case. Multiple angiomas in the periphery. We asked her brother to come to us. Again, it was asymptomatic, and see the large angiomas which you could pick up. This is what it helps you in all this. So this is brother asymptomatic post laser now. Now we are going to do yearly wide field angiogram for this patient. And what we learned, Yes, this is how we did then a genetic part study and all. And this has to be yearly done only with wide field angiography. We would have missed on a routine angiogram. Case number 8, pseudophakia. This is the picture at presentation. She is a 80 years female. This is a peripheral PCV with a encroaching fluid onto the thing. We treated with brolucizumab, and look at the advantages of a large field OCT. Even through the peripheral part, we can have a OCT, the fluid percolating into this. This is the advantage of a wide field OCT image. And we did an angio, we treated, and this is how we can follow up. You can see the tumor, coming down in height for yourself. This is how it happens. Now coming to case number 10. This is a patient who complained of flare in antechamber, decreased vision. You can see multiple fluid pockets across. We did an angiogram. It was a case of a FAF, VKH, which was then subsequently treated, and angiogram showing necessary information. I would just, for want of time, now run through it. This is an ICG angiogram, which is also possible with this system, unlike other, being a multimodal imaging. Case number 11. This is the picture which was diagnosed as a CRO elsewhere. So this is the picture on an ultra wide field. It is self-explanatory. This is a case of a RP with a macular edema. Case number 12. Now she is a premature baby, referred to us for anything. Now look at this. This is the routine standard photograph which was taken by one of my colleagues. And when we did an ultra wide photograph, self-explanatory, retinoblastoma, multiple tumors with seedlings all across into the vitreous. This is so convincing to the patient that you don't need to speak to them further. Case number 13, blunt trauma. This is the picture again taken elsewhere, normal edema, and this is what we see, an horseshoe tear. Another case. This is another case which we see. You can see a subclinical RD over here with a HST over here. This is so convincing to the patient. Subclinical RD, it was in fact posted for an anti-VEGF elsewhere based on an OCT, previous OCT. Case number 15. Now this is a case of a subclinical RD. You could show the patient what it means to have a lattice degeneration. We could treat the laser, do the laser first for the better eye and then treat the other eye. This is how it helps you in convincing the patient. Another case, I will just run through this. These are routine cases now, how it helps. This is another case of, you can see multiple dot hemorrhages over here. This was decompression retinopathy. So convincing to a patient. Another case, if you look at it, leukemic retinopathy. The pictures itself speaks for us. Now we have an additional feature with this machine, what is called a retro mode. So now let's move to the role of retro mode in imaging in macular pathologies. So what is retro mode, to tell you? See, we all know now, are convinced that the hot set of activity in any retinal disease is RP. Most of the diseases now are implicated to the RP because of the various things which are happening at RP level. Now these are the things which are happening. Now let us move. So what is retro mode? What we learned is something like a retro illumination from slit lamp. So when you get on a retro illumination on a slit lamp, you can see structures ahead better in a different perspective. So this is what it happens in this particular thing, where they use this retro mode and how it helps us. Now this is the normal retina color photo. This is the OCT. This is FAF. Okay. And in a retro mode, in a normal retina, you see it normally like this. This is the normal configuration which you see on a retro mode. Now let us see how it sees in a diseases which affect retina. In a macula, this is a case of a typical retinitis pigmentosa. This is the color photo. This is the FAF of that particular patient. The disc is black, correct? Now look at this. You will see that the multiple bully-like RP will be seen here. It will become more pronounced in the consecutive cases which I show you. In a retinitis pigmentosa, RP is not the seat of activity or the disease, and therefore here the RP is not affected much. Okay, now coming to paravenous pigmentary degeneration, you can see wherever this RP is gone, even without doing an ICG, you can see the choroidal blood vessels very well delineated as if it is a ICG picture. This is how it helps us. Now coming to the cone dystrophy. This is the color photo. Look at the FAF. Again, it is not diagnostic. in a RP, here you can see bullies like, it looks like a small bully like thing. You have to get trained to see that. Once you understand what I'm trying to tell you, when I show you, you see these small bubble like things, those are the diseased RP. So if the RP becomes diseased, whenever there is an accumulation into the retinal pigment epithelium, any disease which causes accumulation into the retinal pigment epithelium, the retina becomes such bully like things, bubble like things. It starts looking like this. Now coming to RP disease, this is a case of a Stargardt disease, classic angio, FAF. Again you see in a Stargardt, these are multiple bully like RP, and in all this is more classic, you can see. So the extent of involvement, if you look at a FAF, is quite less of a RP, while in a this particular retro mode, you see the whole diseased RP is quite extensive. So it tells you the extent of the disease in a more better way. Now coming to pattern dystrophy, this is color fundus photograph, and this is the FAF. Here if you see, the RP is affected in a lesser way. Still you can see these are bully like things over here. So this is how it helps you in a best disease. Again, some things which we will run through. I will come directly to AMD now. This is one of the most important way how to follow, because this affects predominantly RP. Now this is a AMD. You see minimal drusen over here, here. OCT is not contributory. FAF again is not contributory. Now look at the disease in this. You can see multiple bullies all across. So look at the extent of the disease, where you can see on a color fundus photograph, FAF is not contributory, while you can see all the bullies, means the extent is quite much more. So we are doing a study where we are able to count the number of RP cells with certain strategies. We will be coming out with a paper in a short while. It is it is sent for publication. We will explain you. Now look at intermediate dry AMD. Again you see few drusens over here. OCT is not contributory. Now look at FAF. Again it is not contributory. The only way to look at RP as on date was a FAF, was the best way to look at it. Now look at F. You can see the whole RP over here. Multiple drusen bubble like pictures. See, this is the thing what we are trying to see, and we are trying to understand what the information it is giving and how it will help us in. So the studies are ongoing over here. Now look at intermediate dry AMD. You see multiple drusens, OCT is not contributory. FAF again few hypo and hyper spots are there, but you see the whole RP is affected all across. So it tells you the extent, and the not only that delineation is much more, the spread is more, but the number of cells are more affected here, which we can pick up. Now look at soft drusens, how they look. Again you can see some on things which you can see hyper autofluorescence, and here you see the whole RP is bunched up. Can you visualize and understand that? That is the beauty of this system. Now look at cuticular drusens. Here drusen, now look at it, the extent of involvement. This is quite a significant one. Now that they are trying to develop the counters by which they can actually calculate the number of RP cells which are involved. And this will help us in better prognosticating. Now this is a young girl, doctor by profession, who came to us with this fundus picture. We saw drusen, we said, okay, you have some drusen, we will be watching you. So this was a dominant drusen, FAF was not contributory, and you see the extent of RP involvement. It is even on the nasal side of the disc. So we could prognosticate to that young girl who is 32 years doctor, that your RP is going to give us some trouble in future. Now coming to infective pathologies, wherever there is a scarring and the loss of RP, the choroidal vessels will stand out as if you have done an ICG. So this is a good way of looking. Wherever there is a RP loss, a choroidal vessels, even without putting an ICG dye, can be seen better, and you can understand the way choroidal involvement. Now case of retinoschisis again. You can see the wide field OCT, how it helps you. You don't need further investigations to understand this. CSCR. Again we knew this is a disease of RP again. But we, on an FAF, when we do, we can at the most see 1 or 2 points. Look at the retro mode. You can see multiple RP bullies over here, which says that the disease is more extensive. It is not necessarily a pinpoint look. The RP is diseased. Now we have started believing clinically as well. Previously, histopathological studies told us that RP was involved. Now another case over here. This is a case of a VKH. You see the bully RPs which are bigger in size. They are more swollen. So in a case of a VKH, the whole disease process again is at a RP level which is involved, and you can see bigger bullies over here. Another posterior VKH case which you can see on an OCT and an again you see all the RPs. Here you see the disease only localized, but you see the RPs all involved even beyond the arcades. So this is what it offers us. So this is the advantage of this particular new system is that it is true near normal color image because it uses 3 lasers. It gives you a SLO based images which are near natural colors. It gives you all the facilities plus an additional advantage of retro mode. The clinical implications, what we could understand and from the literature which is very scarcely available, tells us that it gives you the involvement of RP in a better way. And here we could document that the RP actual, not only the extent, but the actual number of RP cells can be more. That is what we are learning in various retinal disorders. Thank you. And besides that, many people ask me about the questions about what would be the cost of it. This is the cost which you pay. In last 18-20 months, these are the 3 cover pages of ophthalmology for us. This is eye. We have 2 eye cover pages, and these are our publications. Thank you.
Have you seen these in renal diseases? You know, where patients come with renal transplant and ongoing renal disease, because when you look at their fundi, they have all these pigment epithelium changes. And have you done any of these?
Not yet, sir, but we hardly have 3 papers on retro mode available in the whole literature. So for us, we do not have the clue how to proceed with it. We are trying to understand and for ourselves. Now one of my PG student is doing a thesis actually on how to count the number of cells of RP, and probably we will be having a publication. But we are not sure. We are trying to understand what this information will guide us.
Can those larger bullies in VKH be secondary to stromal infiltrations? Because it's a 2-dimensional end pass kind of photography.
No, the thing is, this
Impression that they are RP being involved is only, I think, needs to be verified.
Basically, it is something like this. This RP, the technology picks up the RP, means the RP level only.
Doesn't go deeper.
It is not going because it is the reflection from the behind which is highlighting the RP more. That is the thing. That is why it is called retro mode.
What happens on follow-up, like once VKH resolves?
Yeah.
Do those changes disappear completely, or
The RP becomes more atrophic. The bullies, they flatten down, but they become more thinner and all those things. So we are still, as I said, this is just a 1.5 2 years follow-up with us. We are trying to ourselves understand what this information is going to guide us, and can it be really put into clinical use.
Yeah.
As I said, the technology sometimes you have to pay through your nose, but it is almost 1.4, I think. Yeah. But it's a retro. You need to understand ultra wide field OCTs. You have ICG facility. You have FFA facility. FAF is also there. Retro mode is also there. So everything. This is a multimodal. It's a part of HR. OCT angio is also there. OCT angio is also there.
that comes in one by one?
Yeah.
So then why don't you need to do fluorescein angiogram when you have the OCT angio?
See, OCT angiography, you got only central part as of date. See, even with the size, even if you do collage, you can hardly see this. So, the importance why we wanted to show today's presentation was predominantly what is the utility of this machine in learning why we should look at periphery.
Angiography is a dynamic process, right? It shows the lead. OCT will show you the lead.
No, it won't show, but you can really pick up beautiful images. Like while Nitin was showing, Nitin sir shared few of his photograph. Many of these lesions after otherwise also
The
shows.
neospatial, sometimes the opta still shows the neospatial, but whether they are really active or not, you will know only by FFA.
You can make out from the patterns of it, but yes, definitely. Angio makes it more comfortable.
You'll be seeing them now. After Vatsal will be showing them. Oh, wonderful. I think we'll start with this so we can have discussion again later.
Good afternoon, everyone. Thank you all for coming. I have this technology since the last 2 years, but I wasn't using this modality, that is autofluorescence, till Dr. Nitin Prabhudesai asked me to speak on this, and I'm very grateful to him for that, so that I could start using this tool in my day-to-day practice, and I'll share my brief experience with this. So this is about autofluorescence, ultra-wide field autofluorescence imaging. So basically, it's a non-invasive in vivo imaging modality, which gives us a lot of information about the cellular metabolic. It gives us mainly about the retinal pigment epithelium. And the Optomap AF uses a green wavelength of 532 nanometers. So the basic principle is that we use fluorophores, which are naturally present in the retinal pigment epithelium. And what fluorophore means is that it absorbs light of a particular wavelength and emits light of a different wavelength, which is picked up by the camera, and we generate the autofluorescence images. And so lipofuscin is the most dominant macular fluorophore, and it's increased in degenerative disorders like AMD, macular dystrophies, and other conditions. So what are the indications of autofluorescence imaging? It's basically drug toxicity, optic disc drusen, chronic CSR, choroidal nevus versus melanoma, heretomacular dystrophies, and AMD. So I'll just show you a few case examples of where this technology has helped me in my day-to-day practice. So the advantage of ultra-wide field FAF is that we can image a lot of other findings in the peripheral fundus which are not seen in traditional autofluorescence imaging. So how does a normal autofluorescence map look? So these structures which are black are the optic nerve head, which is due to absence of RPE and lipofuscin, the fovea, which is dark, and all the blood vessels which are dark. And the general fundus will have this kind of isofluorescent grayish kind of appearance. So next we need to know what is abnormal fundus autofluorescence, and that's usually due to the change in the composition of the fluorophores in the RPE. So we need to know only two terminologies. One is hypoautofluorescence, which is the dark areas, and hyperautofluorescence, which is the bright areas. So in short, what dark means is that it means dead. That means dead RPE cells, there's no lipofuscin, so you get a dark signal like this, and sometimes you get it because of blocking or absorption of the light by some other lesions, but in general, black means dead. And examples of these are RPE atrophy, laser scars, hemorrhage causing blocking, exudative lesions. What about hyperautofluorescence? That means brighter areas on the screen, like as seen here. So this is due to excessive accumulation of lipofuscin, and this indicates increased metabolic activity due to sick RPE. So examples are like yellow lesions like pattern dystrophies, some soft drusens, and macular dystrophies. So this is the most important slide. Dark is dead, that is dead RPE, and bright is sick, that is due to increased metabolic activity of the RPE. So let's come to some case examples. So optic disc drusen it's very, very, AF is very, very important in differentiating pseudopapilledema from true papilledema. Now these are two discs which look properly like optic disc edema, but when you do an autofluorescence imaging on these patients, you realize that this is the optic disc drusen light up on autofluorescence, and this is a patient of true papilledema due to a CP angle tumor, and from this you cannot distinguish at all, but you can save this patient from going in for an MRI. Now this is especially true when you have buried optic disc drusen like this. When you have surface drusen like this, where you can see a lumpy appearance, it's, I mean, you know what you're going to get an autofluorescence. What about drug toxicity? So this is a patient whose fundus looks remarkably normal, and the vision is also 6/6. A patient who has been on IC237 for a long period of time, and the autofluorescence shows you a bullseye maculopathy. So there are many drugs which can cause retinal drug toxicity, like HCQ, dinadosine, and thyroidazine. So now this patient has 6/6 vision, but of course this patient is complaining of some distortion in vision, and you can see some RPE changes here. The OCT also shows some degeneration, And the AF shows you very dramatically the presence of bullseye maculopathy due to HCQ toxicity. The challenge is to actually pick up HCQ toxicity at a much earlier stage so that you can tell the patient to stop the drug. There's another patient who came to us 5 years on tamoxifen, and the fundus just showed very subtle changes. The OCD showed this kind of changes that we thought maybe it could be PFT till we got the history of tamoxifen usage. And the autofluorescence showed us this hyper autofluorescent lesion at the foveal center, and we could confirm this of tamoxifen toxicity in this patient. What about CSR? In CSR, we get an area of hyper autofluorescence in the area of serous elevation. And very often we have seen this granular kind of hypoautofluorescence. And usually this corresponds to the leak that we see on fluorescent angiography. So in a rare case, when you are not able to do a fluorescent angiography or something, you could use this for doing for the area of micropulse laser, which I do in this area of leak. And autofluorescence also, wide field autofluorescence helps us in demonstrating these RPE tracks, which are a part and parcel of chronic CSR. You can see all these gravitational tracks almost as well as you can see them on fluorescent angiography. It's another patient with chronic CSR and RPE tracks. And you can see how dramatic it is, almost as if you are doing a fluorescent angiography. This is a patient where you can hardly see any tracks clinically, but you can see this, and this confirms the presence of chronic CSR. This is a patient of a BRVO, which has been lasered and had some fluid at the macula. And by doing a AF, we could make out that this patient, the fluid was actually due to the CSR and not due to the BRVO. It's another patient who had been advised anti-VEGF elsewhere, and you could see this yellowish vitelliform kind of lesion, which was actually subretinal fibrin, and the AF showed me chronic CSR cases. It's another patient that was advised who had undergone multiple anti-VEGFs elsewhere, and this was the OCT picture, and AF, wide field AF confirmed the diagnosis of chronic CSR. What about AMD? AMD in ultravide field, we get a lot of abnormalities in the periphery, which were in almost 97% of patients, we get abnormalities in the periphery as well. So as we talked about earlier, that dark areas are basically dead RPE and photoreceptors. And in geographic atrophy, what we look for is the zone of hyper autofluorescence around these areas of hypoautofluorescence. And this indicates that these are the areas of future damage that's going to happen and the enlargement of the geographic atrophy. So this has also been classified into different forms, and they have different prognosticating this. It's another patient with geographic atrophy. So you can see the zone of hyperautofluorescence, which indicates the progression of the disease. Now, very often we have patients like this with dry AMD, and they have relatively good vision. And you wonder why they are complaining so much. And that's because when you look at the autofluorescence, you can make out that these are all scotomatous areas. And when the patient says that his vision has gone down, and you see on a follow-up case, you can actually see these dark areas increasing. Now, RPE rip can be very elegantly seen on ultravide field. This is exactly opposite of what will happen in a fluorescent angiograph. So here you'll get a complete dark area where the RPE is ripped off, and the scrolled up RPE will appear as hyper-autofluorescent. It's a patient who complained, a 28-year-old lady who complained of decrease in color vision and day blindness kind of thing. And this was the OCT image. And the ultravide field showed us like a bullseye maculopathy, suggestive of cone dystrophy. Some other patients of bullseye maculopathy. And very often you see patients with nearly normal looking maculas, where you can pick up these lesions on. There's another patient where you can see that the fundus looks nearly normal, but you can see a hyperautofluorescent here, indicating a maculopathy. Uh, this is a classic BEST disease. This is in the egg yolk stage and the scrambled egg stage with the OCTs, and you can see how dramatic the appearance is on autofluorescence. Another patient. Okay, this is pattern dystrophy. This is another case of BEST dystrophy. This is another pattern dystrophy. Butterfly shaped pattern dystrophy. Okay, coming to Stargardt's, sometimes you have very early cases where you get this very subtle findings, but you can see some kind of an atrophic lesion here. So when you see the same patient on autofluorescence, you can see this atrophic lesion here showing up as hypoautofluorescence and this zone of hyperautofluorescence. You can also look at these flecks here, which are part and parcel of Stargardt's disease. And if you notice, over a period of time, these flecks have turned black. And these are the, so it's helpful in monitoring of Stargardt's disease, where the active flecks are white and the older flecks, I mean, as time goes by, they turn atrophic. You can also see the zone of hyperautofluorescence increasing here. Hypoautofluorescence, I mean. Coming to retinitis pigmentosa, you can see changes on autofluorescence which are much more dramatic than what we see clinically. So I'll just run through some of these patients of RPE. Sometimes in very, very mild RPs, it's very helpful to do ultra wide field of FAF. Now this is a patient of PPCRA, and you can see it's very elegantly demonstrated here. You can see the atrophy around the veins. This is a very important indication for FAF, that is posterior uveitis. This is a patient of serpiginous choroidopathy. You can see all these healed lesions. You can see some active lesions here, and they show up as hyperautofluorescent lesions here. And the same thing you can see after treatment with steroids. The lesions have the hyperautofluorescence has gone away now. So this is a very elegant method of following up a patient without dilating the patient. Another patient. Then mudes. Before treatment, after treatment, you can see all these choroiditis lesions here. VKH, you can see, this is literally like doing a fluorescent angiogram. You can see all these areas of exudative RD, and this is post-treatment. Another patient of VKH, pre and post. So another important indication is to, when you see a pigmented lesion like this, is it a choroidal nevus, is it a CHRPE, or is it sometimes a melanoma? So then the choroidal nevus disappears on AF, whereas CHRPE appears hypoautofluorescent. So you can give a definite diagnosis to the patient. And a choroidal melanoma has this kind of hyperautofluorescence, granular. So it's the nevus disappears on, so nevus here disappears on AF. This is CHRPE which remains hypoautofluorescent. This is a choroidal melanoma, probably. It's still sent for investigation. You can see this hyperautofluorescence here. So this is the final take home, that black is dead, RPE, and that is the blocked signal you can see here, and bright is sick RPE due to increased metabolic activity of the RPE. And the conclusion is that it should be a part of all comprehensive eye exams because non-invasive. It provides information on the metabolic state and overall health of the RPE. It allows the detection of many pathological conditions with peripheral findings, especially when they are, the lesions are not seen clinically. Thank you.
We have the experience of other technologies with AF later. Now I'll ask.
The next speaker is Dr. Sharad Bhomaj, who will speak to us on spectralis versus optos imaging.
Good afternoon, everybody. I'll just share my thoughts on comparison of these two technologies. Start moving ahead. Yeah. So I'll come to first color photography, comparing Spectralis versus Optos. Now, with color fundus photography, there is no competition here. Straight away, the Optos is the technology for capturing the fundus photographs, because it captures wonderful images right from the disk to the periphery. So the Spectralis cannot do this kind of things. And but there are some caveats. No technology is perfect, like we humans are not perfect. We miss findings, our wide field fundus photographs pick them up. And some things are missed by the wide field photographs, but we can pick them up. So there is nothing which is absolute. So clinical examination remains the gold standard, and these are things to supplement our shortcomings where we don't have time to examine our patients nicely, or a patient who doesn't want to get dilated and you have a quick screening to examine the patient right from the disc to periphery. So this is the application for the ultra wide field fundus photography. Now, whenever the lesions are highly elevated, especially in the periphery, you cannot document this with any other technology other than ultra wide field imaging. So standard color fundus photography or whichever technology, with the depth of resolution which you need, will get only with the panoramic view. So with this technology only you will be able to so again, this is a peripheral choroidal detachment. You can see that this can be picked up only with the ultra wide field imaging. Excellent tool for documenting your pre and post interventions. So again, you can see excellent in the presence of a vitreous hemorrhage where a traditional fundus photography cannot do it. So it provides you a wonderful panoramic view. It is also good for disc cupping documentation. You know, with the standard fundus photography, you have bleaching of the disc, whereas in the Optos, you don't have any bleaching of the disc. You can have excellent cup to disc ratios and with the undilated, extremely good. Then elevated lesions in the periphery, as I said. And the most important thing is it is complementary to your clinical examination, and indirect ophthalmoscopy with scleral indentation remains the gold standard to pick up everything. And it can miss lesions in media haze, uncooperative patients and lash artifacts. So if you don't see anything on the ultra wide field fundus photograph, doesn't mean that the fundus is normal. You have to do your scleral indentation examination. Now we go to the next technology, which is the Spectralis. It works on laser technology and it highlights whatever is there visible to that it captures. It highlights it very nicely. But the limitation is it will give you images only up to 55 degrees. It is very difficult to get a steered views with this multicolor technology. It is not very easy to do it. So for all practical purposes, you can say it gives you good images, but there are some shortcomings. You cannot image the periphery. But the true strength of this Heidelberg Spectralis lies in multicolor imaging of the posterior pole. So I'll show you an example. This is a patient with a 42 years old female with a disproportionate vision loss. And if you see it like this, you can say that the fundus is normal. You will send the patient for MRI imaging. That is what the patient was sent for, MRI imaging for some other. They didn't want to get MRI, so she came to us. On Optos, everything is normal. But on multicolor, you can straight away make a diagnosis of a parafoveal telangiectasia. So for small, minute pathologies, which are very subtle, still for the macular imaging, the Heidelberg Spectralis is a step ahead of the Optos. The true advantage of Optos is to get very panoramic views, but very, very small lesions on the macula can be missed by this technology, which can be picked up by the Spectralis. Again, this is a patient which has got a subtle disc edema, not very sure. If you look at the fundus photograph, you cannot be sure whether there is a disc edema. But when you compare on the multicolor imaging, you can see there is a stark difference between the other eye. And you can see that it is grossly abnormal, the disc. And you know that this is a true disc edema. Again, this macular pathologies, left eye looks normal and right eye has got a ERM, but it's not that prominent. So you can see on the multicolor posterior pole imaging, very nicely you can see the macular pathology, and you can see the pathology even in the left eye, which was not visible on the Optos fundus photograph. So very small pathologies are missed by the ultra wide field imaging. The true advantage of ultra wide field imaging is the periphery, but very small pathologies, minute pathologies of the macula can be missed sometimes. The media is not clear of the, or the fundus photograph is not clear, you can miss images. So that this is the difference. Other thing is that when you want to give printouts to the patient, this is the wonderful technology. You get very good macular images and very good macular OCTs, and you can give a nice printout to this patient, which is also important practically to during the practice. So for posterior pole pathologies, I feel that this is an excellent technology to. We want to suggest the optos people to gear up to have better quality of fundus photography printouts. I am not very happy with the quality of resolution of the printouts. The soft copies are excellent, but the printouts are not that good. Whereas the Heidelberg printouts are excellent. The patients are very happy with the printouts. So color fundus photography, Heidelberg Spectral is good for especially the posterior pole imaging. Optos is excellent overall, but it can miss the minute pathologies. Infrared photography is not possible with the optos, and why is it important? Because of the excellent red-free imaging, you can see that the infrared imaging, not the red-free, infrared imaging, you can see what, the black and white things on the fundus image, exactly where your scan is passing through, what area of the fundus is being imaged is seen excellently with this. So that is the true strength of the infrared imaging, which is very important. Now you can see a wide field fundus photograph. This is a patient of a retinoschisis, and this infrared technology can highlight this elevated lesion much better. So you can see the true extent of the bulla much better with the infrared technology, and it has been better than the autofluorescence. You can delineate this elevated lesion, and you can see that it has been one of the suggested modalities of documenting the progression of schisis, infrared images. It is more sensitive than the fundus photography. This is a patient, I could not get very clear images with the optos, but with the infrared images, I could get this patient of PSCR, a peripheral hemorrhage, and the leaking lesion. So the next technology is the infrared technology. There is no comparison because it is available only with the spectralis. Now autofluorescence, both are excellent, but extremely minute pathologies of the macula are seen in very good resolution with the spectralis. So you want to follow up a patient of a geographic atrophy or for dry AMD clinical trials, this is a more standardized technology and more used for the dry AMD trials. But the advantage of the autofluorescence you have seen in the previous talk, panoramic view autofluorescence imaging is not possible with the spectralis, and it holds its own against this, and it also provides excellent macular autofluorescence, the optos. So more or less they are equal, but if you want to have a very minute follow up of the macular pathologies, I think it is slightly superior and it is more standardized. So for all clinical trials, dry AMD especially, for angiography now the true advantage of the optos angiography is the true ultra wide field, which you cannot get with the spectralis in one go. So you can see these are the wide field images of the ultra wide field images of the spectralis optos, also applicable for these posterior uveitis patients. Excellent. With a single view you are able to see most of the fundus, but the problem is the vertical view is slightly less, so some of the lesions can be missed. So you can see in this patient there is a small angioma here which is mixed by the optos, and you have to be very careful. You have to separate the lids, tape the lids and get a good image, otherwise you can miss lesions. So you can see here there are angioma in the vertical meridian and a horizontal meridian both, and this can be picked up by both, and but the peripheral lesion is not picked up by the single non-steered view of the optos, but the spectralis is able to reach the more peripheral areas in a better resolution. So you can see this is a same PSCR patient with steered views. By asking the patient to move peripherally, you can get excellent images in the periphery. So the ICG angiogram, you can see the multiple polyps. In this case of PSCR, you are able to see. You get very good images even with the spectralis. And when you want to go to the periphery, you have to steer. So this is the case of FEVR. You can see the extensive non-perfusion areas in the superior and temporal and inferior fundus. And with the spectralis, you are able to get excellent quality images. You have to just take steered photographs. In a single view, you will not be able to get, but steered view, you can compensate for this and get equally good images as the Optos. So you can see this is a case of coarse disease. You can uncover all the angiomas and the non-perfusion areas in the periphery. This is a sectoral laser done for Eels disease, and you can see that with the steered images, you can see whether your laser is sufficient, not sufficient. Occlusive vasculitis, again, you can see all the peripheral areas are picked up well with the steered views of the spectralis angiography. We can reach even the aura. So you can say the Optos provides you true ultra wide field. This is some exchange of the headlines. And the Heidelberg remains the gold standard for macular pathology. If you want to study wet AMD or DME, for that, even for the clinical trials, the Optos is not approved, but the spectralis is approved because it provides very high resolution images and reliable images of the posterior pole. As far as OCT technology is concerned, I think the Optos is still catching up, and maybe in a few years' time they will be quite good. They are still not standardized for glaucoma imaging. They don't have Octa. So simultaneous angio and OCT, stereo ICG angiography, glaucoma module, all these things are not available with the Optos as of now, but I think it's just a matter of time. It's a work in progress, and they will have good imaging. So the main advantage of the spectralis is excellent infrared imaging, which allows you to track what is happening inside the eye. So with this true tracking, you are able to know where exactly the scan is going. You can alternate the scan. This is the only machine which will tell you what is actually the machine is doing. You can see the scan pattern. You can see from top to bottom how the scan is taking place. So this is very important point-to-point registration and to know what exact image you are taking. You can get excellent images as well as the OCT angiography. Very good glaucoma imaging, very good anterior segment imaging, which is not yet possible with the Optos. So the advantage of Optos is basically doing the OCT of the periphery. So whether it is applicable for you in your practice, you have to decide. So because mostly for research and publications, you will be needing this a very wide field kind of OCT images of the periphery. So it's up to the clinician to decide. Other things are that there is slight delay in the capture of imaging. So the early angiographic events are captured much better with the spectralis, and where the patient has got poor fixation, media opacities, or in poor dilatation, because you have a joystick in hand, you are able to get hold of these situations in a much better way. Overall, for angiography and everything else and the color fundus photography, Optos remains having an edge because it is going very wide in the periphery and getting in a single shot. But with the spectralis, if you use your machine wisely, you can get all the same information as there with the Optos. So in conclusion, both machines are excellent. You have to learn to do what you have, and both machines are excellent. This machine has got this advantage and this machine has got this advantage. Some drawbacks and advantages are there. So you have to decide which you want to go for. Both machines are excellent. Thank you.
I think I'll invite Dr. Bhatt now to give his talk on Claris.
You've seen almost everything up till now. So this talk is just enjoy the images for the next maximum 5 minutes. It will not be longer than that, definitely. Okay. So the most important advantage of this machine here is it uses a white light, hence it is absolute true color, and the resolution is mind-blowing. You can zoom it to whatever extent you want. A single image is 135 degrees, and you can have 2 or 4 images. 2 images are about 170, 4 images around 210 degrees. You can see right up to the periphery with that. And 4 image montage, you don't see the montage line at all. And it covers, probably 90% of course not the entire retina, but 90% of the retina. And still, it is absolute true color. What you want, we see that. That's the advantage of this. So this is a case of, and it takes a little time, maybe about 30 seconds or 40 seconds to acquire this, but it is accepted very well by the patient, and the color is absolute true to what we want. These are peripheral degenerations, plus can see the aura very well. You need to slightly angulate the machine to see the aura. It could not come in a standard image absolutely clearly, but it still is possible. So this was our fantastic horseshoe tear seen at the periphery. I could pick it up on ultrasound also. Sorry to say that, but ultrasound can also do it. Okay, so the case of choroidal granuloma, which at the right you can see up to the periphery. It's seen very well on USG also. That this image that I brought here is to see the excellent resolution that we have. We can really zoom it out to what he was talking about, the Heidelberg, where you can see the macula, and you can really see the macula at high resolution. So I'm not going to cases. This is just showing you the images at glance. We can all go. The FAF is also very good on that, and it has both blue and green. So you can go to any extent and see that. We had the fundus with healed subinguinous. You can see the two resolutions on blue as well as on the green on the other eye. This is a healed case, and single area can be seen very well. Another case of subinguinous where you can see the entire extent. So this acquires in probably 3 to 4 seconds. It's just 2 images, and they montage automatically. The importance, just the next few minutes, is to have the forum software where you can overlap the image of OCT, the angio, and the fundus on one picture, and you can have one-to-one correlation. But it's not possible on the machine. It's on an external server. Now this patient was a myopic patient. Axial length was around 37.5 millimeters. Such a high myopia, staphyloma. We could see the posterior pole quite well on this. So here, just see this video. We have these images outside. So yeah. So this is the tracker. I don't know why it's not playing. Okay, now it will play. You can move this tracker wherever you want. So you have a fundus and the OCT correlation. This is only simple fundus and the OCT correlation, and then you can add angiography to that particular area which we are interested. So the case of peripheral vascular malformation, which we saw on the nasal quadrant, and on the OCT angio also it is seen very well. Because we know the entire area, we could see it on OCT angio. So we have NVD where you have the OCT, fundus and octa. We can have actual point one-to-one correlation, and the same NVD. The important thing in choroiditis here is that if you want to see the atrophic areas, choriocapillary atrophy that is seen here, you can overlap the two areas of the octa, the choriocapillary slab, and know the exact area. So this is like FAF, FAF, but you can have one-to-one correlation. So this is a case of very high myopia, myopic fundus, and a suspected CNVM. Now, if you see on the fundus itself, it looks like, but we are not very sure. Even it was posterior staphyloma with an axial length of around 32, 33 or so. And then we did the octa over here, and that particular area, I could see the CNVM. I was not sure whether this is a CNVM, but when I saw correlated with the fundus finding, then this area became a myopic CNVM, which could be seen very well on the. So correlation between these three, and the same area can be seen on the OCT also. This is the same area, the OCT. So this correlation is possible with the external software. So this is just the last slide of PB-CRV, which I saw over here. The point home that I want to drive is that it's true color, easy to acquire, very easy to for it to do an auto montage, and you can have correlation between all three and know the exact area. Thank you.